My name is Vivien Sheehan. I'm an associate professor of pediatrics at Emory University in the Aflac Blood and Cancer Division. I'm a physician scientist focused on sickle cell disease. For decades, we had one therapy for sickle cell disease, hydroxyurea, and then in the last now 8 years, we've had 3 FDA-approved drugs. And so it's very exciting to have more options for our patients. However, that excitement is tempered by kind of the modest nature of the benefits of the new drugs and also the really slow uptake from the sickle cell patient community. Less than 3% are on a given novel second-line therapy. I first talked about hydroxyurea and how to optimize it. It does need to be pushed to maximum tolerated dose based on certain lab values, but even in doing that, patient response to it varies. And so some patients get very little benefit. Some providers look only at the fetal hemoglobin that's induced from hydroxyurea and forget that there are other non-fetal hemoglobin benefits, such as reduction in white count and in inflammation, stickiness of the cells. So I commented on that. And then talked about the 3 FDA-approved therapies, how to match them with the right patients. That there are 2 strategies. We can look at the patient's symptoms and pair them with the drug that had that as a clinical endpoint. Or we can consider the quality of that patient's red cells, going kind of to the next level and seeing what drives their particular sickle cell disease pathophysiology and pair it in a more red cell function manner. The big take-home message to me is that we need to have the decision to go forward with a cell-based therapy be the patient and their family's choice, and not be paternalistic and say you must try every FDA-approved therapy for sickle cell first. Not only is that inappropriate, but their level of benefit, even with good response, does not equal that of a cell-based therapy, nor does transfusion. And so it's appropriate for families that want a more transformative therapy, something more closely approaching potentially a cure, to be able to go straight to a cell-based therapy rather than try and fail everything that's out there for their disease. So the challenges are right now going to be access. Again, who is sick enough to get this therapy? Being that kind of, having that gatekeeping attitude of you must have this many pain crises, you must have this much organ damage. Whereas I would prefer we take a preventive approach and avoid all of those things and offer cell-based therapies to those who are ready for it. So that kind of gatekeeping is a concern, and then how it's going to be paid for, what will end up having to go to the company, what's going to be provided to hospitals for the actual care of the patient, because all of this is going to potentially impact how many patients can access cell and gene therapy for their sickle cell. I mean, there are other therapies in clinical trials for sickle cell, some very novel approaches, and so it definitely bears watching to keep checking in and seeing whether more potent versions of existing drugs may come closer to having more definitive management of sickle cell disease, but it still needs to be, again, the family's decision what path they take.